This is the Doc Nation podcast. We are a movement founded by doctors, for doctors, dedicated to empowering medical professionals to reclaim control over healthcare decisions and advocating for their fair share of the industry's resources. Please note, the views expressed are those of Doc Nation and not necessarily those of our guests or referenced health centers.
We are excited to announce Dr. Kelly Cawcutt on with us to talk about her experience in healthcare. She has been in many parts of the country with her practice and has a lot to say about what it's been like to go through multiple different avenues. And so we're going to dive into that shortly. But before we do, Reed, do you want to give some sound bites to our audience?
Yeah, I'd just like to let everybody know as we switch from our Tuesday night at 8 o'clock, 8:30 to what'd you say? Yep, the webinars. Thank you. To the podcast. Our goal here is to keep them to 15 to 20 minutes. We want you to be able to jump in the car and listen to us on the way to work and jump back in the car on the way home and listen to another short one. So our goal is 15 to 20 minutes of high quality content. And we thank you for joining. So here we go.
So Kelly, tell us about you. How'd you get into healthcare and what are you doing today? What's your role?
How I got into healthcare. So I'm a first-gen college grad, actually, in my family, and probably got into healthcare predominantly because I was a sick kid and had a ton of exposure to healthcare and loved science, and eventually really liked talking to all of my doctors, and ultimately kind of chose that path in undergrad. So I was not a early on decision of going into healthcare or medicine, but decided kind of going in through undergrad that I really did love the biosciences and was going to apply to medical school. Entered medical school and went to medical school at University of Minnesota in the Twin Cities, not the Duluth campus, and did my internal medicine medical school there, and then internal medicine residency also at University of Minnesota. I then decided to be a little less typical in pathways after residency and looked for an opportunity to proceed to do both infectious diseases and critical care medicine training. I talked to many organizations around the country. At that time, it was not a common nor easily found dual specialty training that you could find, and ended up being offered an opportunity at Mayo Clinic in Rochester to train there and do both fellowships and my master's of clinical and translational science across those fellowships while I was there. So went there and spent 4 years at Mayo, completing both fellowships and my master's, and then got recruited to Nebraska Medicine, UNMC, during the Ebola pandemic to come down and join faculty here with some of the faculty that were transitioning out of the infectious disease division and out of the infection control world there. So I've been at Nebraska Medicine now since January of 2016. I currently serve as the medical director of infection control and hospital epidemiology and the medical director of acute care quality for Nebraska Medicine as a full entity. And today I am here doing this interview and doing other administrative roles and communication, spending a lot of time prepping for flu season, vaccine season, Mpox, all the viruses that are hitting the news in all the aspects right now.
Was there something in your
nail of me?
Yeah, that was well done, and congratulations, and thank you for your service to get there. That's not an easy path, and many lives will be not only saved but impacted in a positive manner because of the work that you've put in. So thank you.
Thank you.
So you were talking about your life growing up. Was there something that captured your interest about infectious disease specifically, or is it more so just learning about it through medical school and residency?
A little bit of both. I would say my initial first love was actually critical care medicine, but I did not love pulmonary medicine. It was not an area that I could see myself practicing in long term. I loved infectious diseases when I spent some time with it because, much like critical care, you never know what you're going to see next. It's any organ system, anytime. All of human pathophysiology could be impacted as you're seeing patients. But I did have an event when I was in medical school that probably tipped me a little bit towards it too, which was having my grandfather die of septic shock in an ICU that I was rotating in. and so had a very close to home impact that I don't think initially led me down that road, but ultimately I think he was kind of a thread across that critical care and ID side of my world. Knowing that they were so heavily tied, and that was under recognized at the time I was doing the training that I chose to do.
Gotcha. That makes sense. Tell us about what you see today as why is it difficult to be a physician, to be a doctor in healthcare with the direction that things have been going? What are some of the things you're encountering?
I think there's a lot of things in healthcare that make it difficult currently to be a physician. I know one thing that you and I had the opportunity to talk about offline was women physicians have a harder time in many aspects, from training through promotion, pay structure, and ultimately even moving into leadership positions. And that has been a continued data-driven disparity in the medical world, which is a hard thing to overcome. And when we kind of look at Women in Medicine Month and, you know, some of these initiatives that get some press with that, it really is because of that disparity and that struggle that it will be a harder road, especially for women in male dominated fields, but even in non-male dominated fields, those disparities still very clearly exist. So that's a very close to home piece for me.
Sure.
But
Yeah.
there's a lot of other things related to the critical care, the infectious disease side that are always top of mind also.
I'd love to have a follow-up question on that, because I agree with you 100%. And I think on a previous podcast a few weeks ago, we talked about how starting a family is just easier for a male than a female, right? If you're going to have the baby, you have to carry it for 9 months. And in the main time that you're in residency, and you did a lot of training, right? And kudos to you, like Reed said, that's impressive. It's hard to start a family during residency, during fellowship. I'm not saying it's shunned upon, but when I trained, it was not optimal. Is that a good way to put it? I remember.
Oh, absolutely. I mean, I was point blank told to take off my wedding rings when I was interviewing for positions at certain places, and told to not talk about whether or not I would ever have children. I mean, I went down that road very clearly.
I mean, that's just not, it's out of control. I remember one of my co-residents, I was physical medicine rehab, and our first year was internal medicine. And she was pregnant, had a baby, and they wanted her back in 2 weeks. And we're like, we'll cover it. Like, what are you talking about? 2 weeks? Like, she just had a baby.
Yeah.
And they're like, oh, if she, you know, she could take more time, but she could do this, but. And it was just so disheartening for all of us that we're all excited for one of our residents to have a baby. And you're like, how do you, and she came back in 2 weeks. And I was blown away. I'm like, how I can barely take care of myself right now in residence.
Was that male leadership or female leadership that were pushing?
It was male leadership at that time, and honestly, that there were some other issues.
There were issues related to that, even from overarching national training policies that really did not allow significant parental leave for women, and you had to use all of your vacation at all for maternity leave. Even that you might not get, and you have to make up all of that time, which pushes you off cycle then if you're going into getting hired for a job, if you're trying to enter a fellowship. So I mean, I ended up going through things off cycle based on when my son was born, and you know, you're not on track with everybody else. It makes it much more difficult and an extraordinary amount of negotiation, and without strong advocacy either from yourself and others or someone in a program who's going to advocate for you, it can be extremely physically traumatic, but also just emotionally traumatic, because you don't have that time to recover. And I actually remember after my son was born, I was able to come back. I came back right at 6 weeks, but I went right into a senior ICU night float at a level 1 trauma center where I was the only trainee on call.
Yeah, it's just unjust right now what happens. And going off cycle, for those of you that aren't physicians, is a big deal. I mean, you're applying for fellowships against everyone else. Everyone else is getting their fellowship in July. You're trying to get it in August or September. Most fellowships won't take someone off cycle because it throws their whole curriculum off cycle. So
you have to defer a whole year then potentially. or not, or choose not to, or again, have a, I was able to do some weird negotiating kinds of things with mine. And, but yeah, I was very off cycle, both with timing of fellowship start and with timing of starting my faculty career. I mean, I started in January, everybody starts in July. So even trying to find a position sometimes can be difficult if you don't have something outlined in advance.
Yeah, and just because you want to start a family, that's just unfair at the time that normal people start a family. Not that
Right.
it isn't normal to start earlier or later, but the majority of the country starts a family at that time. It's not like you were doing something extraordinary.
Right.
And to me, it's just it's not right. We have to fix that problem. And this is the kind of stuff that leads to physician burnout too, because you have to sit there and think about your kid, and then sometimes there's resentment towards the kids either. I'm not saying you had that, but that threw me off cycle. That's why I didn't get to my fellowship. Is it because you had a child? Like, that's not okay. If you got in trouble and it threw you off cycle, or other reasons, I get that. But because you had a child, I just don't agree with that at all.
Yeah, and I think a lot of the resentment truly goes to the system now, because people recognize that as a problem. But there's another gap after that. So you're off cycle, and say you have a delayed start to your fellowship. The downstream impact, though, of that reality is that there are several missed opportunities. And you see an attrition of women at mid-career at what would be academically that associate level professor, 5 to 7 years, because for the women who, whether you choose or choose not to have a family, this gap exists. But particularly amongst some of the data with women who have families, you still tend to do more of the home additional non-professional life work compared to if you have a male partner in your home. But that means that those are the hours that you don't spend doing the research, writing the papers in fellowship. They delay your capacity to move forward. And there's multiple examples of being, over-mentored and under-sponsored for opportunities, because people frequently, when you look at literature and experiences personally, you have this gap of saying, well, you have a young family, so we're not even going to offer you that opportunity because you're busy. And I've had that exact thing told to me. Well, we didn't even ask you if you were interested because you have small kids. I'm like, that's not your decision. That's my decision.
Like, they're doing you a favor too. That's how it's brought up. Like, oh, I didn't want to bother you with that. Because Right.
And I think similarly, the bias is very different between men who have children and women.
100%.
So, one of the kind of most memorable moments for me was having a male physician tell me I could either choose to be a good mom or a good academic doctor, but I can't do both.
Jeez.
And unfortunately, I don't have a lot of reserve for that commentary. And so, at that point, it's kind of like, well, did you choose to be a terrible father too? I mean, you're a successful academic physician. Like, are we not the same? But that's not the perspective that's seen. It's not an equitable perspective on men versus women in any aspect of, from training, parenting, whether you choose to have kids or not, and the impact of that bias that kind of is pervasive. Because if you don't have kids, everyone's going to ask you why you're not.
Right.
Which is the downside too. You will be perpetually asked why you don't have children.
By everybody, not just in medicine, by every friends, family, particularly.
Right.
So when we were talking about this the other day, Kelly, you were saying that scratching and clawing to get your way, it's like 10 times the effort.
Yes.
Do you have any examples or like things you would share? Because normally we're talking about the problems in healthcare on the scale of like the system, and this is very much attributes of the system.
Mm-hmm.
How can other women, from your experience, can they learn from what you've done? Have you found some successes? Have you overcome any of these obstacles that you've encountered? Because you're very confident, it sounds like, in how you're dealing with these things nowadays, and maybe before. Did you always have that level of confidence, or was it something that you developed along the way?
I think I had some of it, and I think some of it developed. And I think because there is like truly published literature that is related to this, which I've participated in some of those publications, and I've spoken at different conferences about this, and been part of some of those research projects. There's the lived experience, there's the learned experience, and then there's the research driven, how do you train from that experience? And I think all three of those have been very important to me. I think that one of the most dangerous things, though, is actually to ask women how they should fix it. This is a systemic problem. So if men are not driving part of the solution, you are actively part of the problem. And I think that's really important. And that is true, not for gender disparities, but racial disparities, transsectional, intersectional disparities. If you put the burden of the disparity on the disparaged to fix it, you are only actually driving the systemic problem to be worse. Why should those who have been suffering more from that be the ones to solve it? And when you look at healthcare disparities and you look at your expertise and the people driving those change, it is still very heavily driven by the people who have actually struggled the most. So I think, one, there's a lot of ways to move through that process, but two, this is a collective problem that needs to be addressed in the system, and you need to have active engagement on all sides to fix it.
Yeah.
Just like you do regarding maternal mortality, right? You can't just ask women and OBs purely to fix the issues of maternal mortality, in which African-American women, have, and Black women have a higher mortality. That is something that has to be built into the system, not just in those populations or those specialties.
Definitely needs a collaborative approach, no question. So is there anything else that you would suggest as Doc Nation, as the people who want to see change and are pushing change? What are some things that we can do, or that ideas you may have that would help us be able to do more in this area?
I think things that are really important are, one, be aware that this exists and acknowledge that it exists. You can't do anything if you're not acknowledging the issue and the problems that are gender, other disparities in healthcare in general, right? And two, when you are looking at something where there's implicit and explicit bias, like gender in medicine, there's really the simple opportunity to choose to be an upstander, where when you see it, you say something, versus a bystander who observes it happening and doesn't take that chance in the moment to do something different. So, if you're sitting in a committee looking at candidates for a new role, how many women are in that pile of candidates? Is it equal proportionality wise to your population of women and men in that specialty? If not, is it because there's no qualified women, or because somehow they got weeded out because of concerns for bias? Is it truly that they're not qualified?
Because they were wearing a wedding ring.
Right, because they were wearing a wedding ring, because someone assumed that they didn't have time, or they weren't interested because they may not have been as verbally aggressive. I think also similarly, when you look at some of the data, when men apply for a role, if they have 50 to 60% of the attributes or training, they're considered competitive for the role. That is not necessarily true for women. You really have to be higher than that. You really have to almost out-credential men to be considered equitable in that capacity. And so being aware when you're looking at applications, if you're writing a letter of recommendation, when you're looking at someone who's going to get promoted, are you looking at that group equitably? And frankly, from all lenses, gender, race, all of these pieces, because representation in healthcare in this country matters. It's hugely important to so many of the systemic issues impacting healthcare across the country. And I think for women who are struggling, finding other women mentors outside of your geographic constraints, if you can't, is really important. There's a phenomenal number of fantastic women in medicine conferences that can help provide education and coaching for women. They're also open to men, and men do attend to also learn similarly.
I was just about to say that. I go to the Women in Medicine conference in the pain field. The pain field is dominated by men, and we have some amazing women in our field, and kudos to them. They rise to the top. I mean, they stick their heads right in there and get it done. And that's because that's their personality. But I love talking to them and collaborating with them. And I love that you say representation, but even more than it's not about representation. There was actually data that's come out about women surgeons are better than men surgeons. Like that data came out. And
there's data about internal medicine too.
Yeah, it just came out. I saw on the surgery side like 6 months ago, and everyone just kind of stared at it. And it was a real, that it was, they looked at it and everything like that. It's like, all right, so this isn't just representation anymore. Maybe they're better, or we're better. Like, I don't want to call it just representation, because I hate the thought of a woman getting put in a position just because she's a woman too. Like, she's good at that and really good and deserves that spot, not because people are like, oh, she's a woman, that's why she's on the board, we needed one woman. I hear that all the time too.
Right. And that's very much an example. I mean, again, whichever group it is, that's very much an example of tokenism, which happens for women and other represented people, right? We're like, oh, we have a board and there's 12 members, but as long as we have one woman, we're okay.
Yeah, exactly.
The token.
That's not
one woman, one person of race. Like, it's
Right.
like, it's like you check the boxes. I'm like, is that really, that's not what we did here. Like, this isn't, we shouldn't pat ourselves on the back for doing that. And it's easy for me to say, obviously.
There's definitely a progression in that of moving from tokenism to truly finding, equity in board membership, leadership positions. I mean, that's true in authorship, right? And, our medical society components. I actually suspect I know some of the people you're referring to in your pain field. And so, there is that need to think about the difference between, fair and just, equality and equity, and avoiding having people be a token to, click a box to say, oh, well, we have someone here. But because unfortunately, when that happens, oftentimes too, they're there, and that is exactly the mentality. We checked the box, but we don't value them the same way, like they belong here. We just check the box that someone's at the table.
Yeah. Yep.
So
this makes me think about physician burnout, and think about the road that Kelly's had to take to get where she is right now. Yeah. Like, that's at least times 10. I would say times 10 in the burnout field. It makes me think about a podcast guest that we had, Dr. Allison Cotton, who founded a physician hotline where physicians have actively taken their own life on the phone with this physician hotline. And I just get a lot of the passion coming from Kelly that we got from Dr. Allison Cotton. And it's really, this podcast, got to be honest, has opened my eyes. We talk to doctors all day long, and I'd say a good portion of them are male, and they're burnt out. And I'm just thinking about Kelly, and I'm thinking, you got to be burnt out. And I'm just hoping that today you're wearing your wedding ring. That's it
was a very short-lived run of things, but there are those moments of interviewing and doing different things over the course of my years of things that I would never do again, that I certainly regret doing to fit in the box of what I was supposed to look or act like or be like, trying to become a physician. And yeah, you learn from those, but you don't forget them. And, we still see these moments, even now, some patients do not want a woman physician. They don't think we belong there, or they always assume I'm the nurse.
Yep.
Or if my intern is taller than me and looks older than me, he's clearly the one in charge. And, you still see all of that. And so I think, there's data for burnout related to this. There's burnout, obviously, that's a massive issue in healthcare in general, and certainly escalated profoundly with the pandemic and post-pandemic states. There is data, you speak about surgical data, it's there across the board too, that when you have a group of healthcare workers who, again, are in some way suffering from a bias, disparity, or underrepresentation, that burnout tends to fuel further, and often does appear related to imposter phenomenon mixed in with that, because of the kind of silent messages that you're just not enough as you are, that cycle through that, and that just fuels that fire, and it's really hard. And that is part of why you see the attrition of that mid-career age group leaving medicine, because of those issues, and trying to kind of navigate through that is complicated. And it's very, very true in academic medicine, but it's true in private practice. It's true in hybrid practices. It's just different professional experiences sometimes in those different arenas of healthcare.
Professionally, having to wait 10 years to start making decent income, then being told you have to wait to build a family when that's not the right time of life necessarily to wait. all that together, we talked about representation. I think about how this study or whatever you said, Anthony, about the results from that women are doing better.
They're better female surgeons.
Better female surgeons.
Better outcomes. Better
Better outcomes.
Female
So,
surgeons than male surgeons.
I think
For the
your awareness.
same surgery.
Yeah, I think Kelly, your awareness piece, the awareness factor, like women make healthcare better is kind of what the common denominator that I'm hearing is. And so like, let's actually view them that way rather than viewing them in the opposite. And this representation piece with Christiana Care in Delaware, the largest health system there has a union now. They just formed a union. They voted, the doctors voted for a union. There's the residents striking in Buffalo, in New York. Like, we're probably going to need to think more about what women can do in terms of by supporting them here in this topic from an organization perspective, because they make healthcare better, and we need them. They're critical.
Well, and I think too, you think back to times of training, right? Like, I mean, I knew what it was to work more than, a 24 to 30 hour shift in training. I worked more than 120 hours a week. Those things don't necessarily happen anymore, or they're not supposed to.
Mm-hmm.
But the issues just systemically of inhumane treatment to some ways of healthcare workers, of assuming that you can work ridiculous hours in perpetuity, right? That the standard working hours should always be profoundly more than 40 to 80 hours a week, that you should be able to be on call, so much more. I mean, and yes, there's a professionalism, there's a calling there is some capacity that, of choosing this, right? And then the flip side of that is, at what point when you have burnout and you have trainees struggling and you're struggling to maintain your future healthcare workforce, do you start from the beginning and say, maybe we actually revisit medicine and how we've structured how people live professionally, functionally in this? And a great example was the loss of nursing through the pandemic. I mean, heavily abused, in the pandemic in many areas, if not all, overworked, multitudes of physicians profoundly overworked. The attrition was phenomenal that happened with, what some dubbed the Great Resignation in general, right?
Yeah.
And that's a systemic problem of being understaffed, not having redundancy in systems, and not being able to have people have time off, time away when you're sick, the ability to take maternity leave or paternity leave, right? Like, these are all critical pieces that need to be addressed, like the rest of the business world, in ways to say, you have to be able to treat people in a way that they want to continue to do their job. If you don't, they will burn out and they will leave because they can't have any component of non-professional life. And that's a struggle that's made some improvements over the last, 10 to 20 years, but probably nowhere near enough.
And honestly, in the end, it'll benefit the patient. If your physician's happier and not burning out, the patient will do better. And that's where this has to come from. Is that it's not, everyone thinks it's physicians complaining at this point, but it's not that. We just can't take care of patients the way we'd like to.
Right. And there is clear data behind that. Burnout and infection control. If you are burnt out, you are less likely to do all of the things you need to do to prevent your patient from getting a healthcare acquired infection. That's a known entity. So how do you avoid burnout? It's not by adding more tasks to a burnt out physician. It's not by asking people to do yoga or go to find time to do additional resiliency class. That doesn't actually help. By nature, anybody who made it that far is already really resilient because they lived through medical training. It's understanding it and really looking at it from the organization and systemic standpoint, more than putting the blame again on the people who are suffering.
Yeah.
And you have insurance companies posting record profits.
Mm-hmm.
Yeah.
That's clearly a sign that the cash flow running through all this, demanding more from doctors to see more patients, to have less time per patient. The solution is physicians and doctors need to do more. Well, actually, that wouldn't be the case.
Reimbursement for everything you do, where you have to do more to even, meet kind of that same income requirement, whether you're physician-based that way or whether you're, a hospital organization looking at your income. If we continually have cuts back on those efforts, you just can't maintain the same level of patient care in the setting of those financial constraints.
So I just think that's interesting with regard to our last episode we had talking about, again, how the insurance companies have gotten in the way. Think about how this has perpetuated our problems with the gender gap here.
Right, exactly.
Forcing pressure, all of this, when there's just, the dollars are not there. They're continuing to be taken away.
Cash flow is fine in the healthcare system. It's more than fine. It's where is the cash flowing to that is the problem.
Right. So, Kelly, appreciate you being on.
Well done. Well done.
Love your input here, and look forward to visiting with you more.
We have a large platform, and I hope that freed up some of our physician clients to maybe reach out to us, female physician clients to maybe reach out to us, and maybe if we could put them in contact with you, just maybe for a word of encouragement or something like that. I think that would be really, really cool. We will be respectful of your time, but I'm inspired, and I think someone on the drive home today or next week, whenever we get this posted, will be inspired as well. So thank you so much. Very impressive.
Well, thank you. I appreciate the opportunity.
Have a wonderful day.
Thank you, Kelly. Very nice meeting you.
Nice to meet you also.
This has been the Doc Nation podcast. If you like what you heard, be sure to subscribe, rate, and leave us a review on Apple Podcasts, Spotify, or wherever you are listening to us. Your feedback really helps us reach more listeners like you. We'd also love to hear your thoughts and any topics you'd like us to cover in future episodes. Don't forget to follow us on Facebook, Instagram, and LinkedIn for updates, behind-the-scenes content, and to join the conversation. Thanks for listening.